Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Psychologically informed physical therapy began with investigating safe and effective ways to prevent and treat chronic musculoskeletal pain. Psychologically informed physical therapy blends psychological methods, strategies, and techniques within a physical therapist evaluation, treatment, and plan of care. What started with chronic pain has now evolved into a deep and global understanding that physical, behavioral, and mental health are inseparably interconnected with overall health and well-being. And this is important when you consider that 1 in 5 U.S. adults lives with a mental illness, and many more struggle with stress-related chronic illnesses, such as chronic pain. And if you're a physical therapist, understand that there are many studies out there that demonstrate that upwards of 75% of the patients that we see in clinical practice may be struggling with one or more mental health challenges. This means that the report of patient distress, things like anxiety, depression, and fear, are no longer an optional invitation, but a requirement for physical therapists and other licensed healthcare providers to address the cycle of mental illness and to promote mental well-being. How can a physical therapist or another provider begin to develop and practice and see their patients through this new psychologically informed lens? First, it requires that you study one or more psychological theories or methods. The most common are cognitive behavioral therapy, acceptance and commitment therapy, motivational interviewing, or mindfulness. The 4 just mentioned have the most research to support them and evidence that physical therapists can deliver this type of care effectively. It's acceptable to patients, and that we're able to deliver this with high fidelity, meaning we stay faithful to the model. Is there evidence supporting this type of care, or is there evidence supporting psychologically informed care? And the answer is yes. Physical therapists have treated back pain, neck pain, lower extremity osteoarthritis, specifically of the hip and the knee, as well as other conditions such as headache, fibromyalgia, and chronic regional pain syndrome. This type of care has been delivered within interdisciplinary pain centers, as well as by the solo private practitioner working in an outpatient setting. And there are multiple high-powered quality meta-analyses that demonstrate that psychologically informed physical therapy improves physical function and disability, as well as the psychological components such as fear, pain catastrophizing, anxiety, depression, self-efficacy, mindfulness, acceptance, values, psychological flexibility, and promotes a faster and smoother return to function. How do you begin to deliver this type of care? Well, it starts at the initial evaluation. You have to have some type of validated patient self-report measure to measure the psychological components that are related to behavioral health. Once you've implemented this validated self-report into your initial evaluation or your initial assessment, the next step is to then discuss the outcomes with your patient during the initial visit and discuss how this is one component and not the cause of chronic pain. Always begin by addressing this during the first session. One of the biggest challenges I see with practitioners when they first begin to use psychological care is that they wait until they notice that the patient's not doing so well. Then they insert a mindfulness exercise or a cognitive exercise, and it leaves the patient confused and frustrated and sometimes feeling stigmatized, for they now feel that they're once again being told that pain is all in their head. So these interventions should be a consistent through line from the initial evaluation at most treatment sessions all the way through to the end of the plan of care, and of course, any evaluation or reevaluation. This is the most beneficial care available for people living with chronic pain. Given the breadth of existing research, it's time that we translate the evidence into practice as it relates to health promotion, prevention, and the treatment of chronic, non-communicable disease, as well as chronic pain. Today, I share with you voices from around the globe of physiotherapists that are using psychologically based tools and techniques to treat their patients with chronic pain. We'll begin today with physical therapist Zachary Stearns.
So we start with a standard screen. This is where ideally there's a screen either before the evaluation itself or during the evaluation. And then from then, that initial screen, again, can look different based on what setting you're in. And then from there, then we engage in shared decision-making with the patient. Now, this is really so important to me because we need to make sure that the patient is on board with our plan and then it thinks it's a good idea. And that does include sort of giving a rationale for asking these questions that we've talked about before is the importance of framing it in a way that we just want to make sure we get a glimpse of everything that we need to know to make this the best treatment possible. And then from there, the shared decision-making aspect can, what we think, lead to 4 general pathways. One pathway, standard physical therapy, it's hard to define that, but really what we mean is that we certainly know that exercise and physical activity is very helpful for those with musculoskeletal pain. We certainly know that there are specific exercises out there, and as well as general exercise that's very helpful. We know that a multimodal approach that incorporates exercise and manual therapy is worth considering. And above all, we know that self-management is so crucial for those with pain, particularly with musculoskeletal pain. And so therefore, for many people, we don't necessarily need to incorporate some different psychological interventions in our practice. And so therefore, if someone were to present with no positive screens in the OSPRO yellow flag tool, then we would say we don't need to necessarily move forward with progressive muscle relaxation or say activity rest cycling, these other psychological skills. But for some people, if they were to screen positive, then we can consider one of a few different pathways. And these other 3 pathways, there's either a more psychologically informed physical therapy practice in which we use some different psychological skills or interventions. And then another pathway is doing that psychologically informed physical therapy, but also considering a referral, particularly for someone who presents with signs or symptoms of mental illness, in which case we say, I, as a physical therapist, am not the expert to treat clinical depression or an anxiety disorder. And therefore, we want to expand the team around the patient to make sure that we have professionals who specialize in treating their own respective conditions, their own respective specialties. And then that last category being immediate referral for someone who's in either a suicidal crisis or something that's very, very severe and needs immediate intervention. And then the final step is really an ongoing step of treatment monitoring, in which case as 2 weeks go by, as 4 weeks go by, we're reconsidering how things are going, not just in terms of range of motion or strength, endurance, but also in terms of the psychosocial profile of how someone is thinking or feeling or acting in their context living with pain. And then that can therefore go back to inform our shared decision-making moving forward.
Next up is physical therapist Jeremy Fletcher.
This particular question about working with adults with chronic pain. Well, first, I think it's a matter, from my perspective, my experiences, both personally and professionally, the value that this shift in perspective from what's wrong with you. In other words, let me go and evaluate someone from a deficit-based perspective. In other words, I'm going to go through and collect a whole huge list of all these things that are wrong with you or impairment, if we're using the ICF language. And then we're going to develop this plan of care to address these impairments. I think the fundamental shift that I've made in my personal clinical practice as a result of using the trauma-informed care guiding principles is that, A, I want to recognize that your previous traumatic experiences may be influencing your ability to decrease the threat response and thereby decrease the amount and intensity that your pain that you're experiencing. So that is a part of what we kind of know is pain neuroscience education. So we deliver this information about how the pain experience is, what the nervous system is doing. What I have found, though, is everybody's got this story. And everyone has this story, and they need to feel heard, and they need to feel listened to. So if we're using the trauma-informed care perspective, what happened is what we really want to listen for, is what did happen. So when we are hearing that, the essence of listening builds this therapeutic relationship to a greater degree than my previous experiences where I was entering into this relationship looking at someone from a deficit-based approach. Now I look at someone from a strength-based approach, and I want to know, how did you manage to overcome the adversity that you had before? What are the skills that you did learn before to overcome this adverse experiences? And how can we apply those today?
And now let's meet Canadian physiotherapist Carolyn Van Dyken.
We do have some evidence that people who are catastrophizing, which is a normal phenomena, like let's not make that pejorative or judgmental in any way, shape, or form. I always say to my patients, we all catastrophize, right? That's normal. If I sprain my ankle today, I'm going to start to freak out a little bit and go, I've got to teach tomorrow. I've got to see patients the next day. Like, how am I going to get through this? So catastrophization serves a function, but when we get stuck in that mode, it actually is highly connected with persistent pain. And so we do have research that catastrophizers, people who are kind of freaking out about their pain, do much better with pain education, or people who are fear avoidant. So using the Tampa scale of kinesiophobia, for example, which isn't a perfect scale, but it's the best one we have for fear right now. Maybe the fear avoidance behavior questionnaire. That's the one I'm thinking about. I don't use it because the work component, I don't see so many WSIB anymore, workers' comp. So again, when we use a screening questionnaire, it helps us to tailor what the person in front of us needs, right? And I always use the example of my daughter-in-law, actually, who had chronic low back pain for about 4 years. And in COVID, at the beginning of this year, she was really suffering with this back pain. She had gone to see a chiropractor. She lives about 3 hours away. I had sent her to a couple of different clinicians. She wasn't getting any better. And finally, I said to her, hey, would you like me to take a look? I'm going to treat you like a patient. I gave her all the questionnaires and I just started from scratch. Because, we do what we do with a lot of friends and family. We just kind of jump in and give them a suggestion and kind of leave again. So I actually treated her like a patient this time. And what blew me out of the water, and she knows we've actually recorded her session, so she's okay with me talking about this, but she's a beautiful 26-year-old, vivacious, gregarious, outgoing phys ed teacher who was starting to become very fearful about participating in her phys ed classes because of her back pain. And her catastrophization was in the severe level. She was convinced at this point after 4 years that she really needed surgery. And so what we had to do was a lot of pain education with her. I would never have guessed, Joe, that her catastrophization was that severe unless I had actually measured it, right? And so I think when we use questionnaires to really help us profile the person in front of us and figure out, are they avoidant? Are they fear avoidant? Are they experiential avoidant of activity? Are they catastrophizing? Are they stressed? Are they depressed?
And now over to Spain to meet Javier Martinez Calderon.
In my personal view, physical therapists have modulating cognitions and emotions related to pain for decades. Each time that a physical therapy educates their patients, beliefs, thoughts, and emotions are modulated. It's incredible how we try to promote self-management to our patients without altering cognitions and emotions related to pain, because we need to create a therapeutic alliance firstly, and then we need that our patients adhere to the intervention. So in both steps, the modulation of cognitions and emotions is essential. I think many physical therapists are still uncomfortable using mental skills, for example, motivational interviewing, when treating patients with persistent pain. Indeed, there is a lot of evidence supporting that beliefs, attitudes of health professionals who believe that pain is always caused by a tissue damage, difficulty their return to the normal activities to their patients. No? So I would like to encourage different pain clinicians to investigate further about the importance of the biopsychosocial model of chronic pain and how we can apply this model in our clinical practice.
And then we'll jet over to Ireland for physiotherapist Mary Grant.
So, living well with pain is a really difficult concept, isn't it, for all of us, really, patients and clinicians. It doesn't sound right, living well with pain. So it's a tough one. I think the first step is to acknowledge the patient's journey to date and what they've tried already to get rid of pain and how this has worked or maybe not worked for them. And then what I love about ACT is using metaphors like storytelling to try and maybe help the patient to see that maybe there are other ways around this, that maybe it's okay to drop the whole trying to control the pain or rid of the pain agenda, because that can be really hard for people because, of course, that's what they want to do. Yeah. So I think that they have to kind of go carefully with that with people. And then the next thing, I suppose, once you've kind of got that suggestion out there that maybe controlling the pain is not maybe the most beneficial way to go. Maybe they're ready to try something new. And that's where I think clarifying what values for them as humans, like what they care about most and who they care about most in their lives. So them as, and that's, I think, the next big thing that can really help them to go on the path towards going back to what they want to do or be. I think it's different.
And then it's Italian physiotherapist now living in the UK, Davide Lanfranco.
Thought suppression is about anything but allowing the thought to be there. So distracting yourself, watching the movies, putting the music on, trying to think positively. That belongs to these very toxic messages that are delivered by the society, think positive, positive thoughts, positive vibes. Just put away everything that is scary, negative, and it is not nice, and just replace it and change it with positive stuff. And these toxic messages leads us to the understanding that negative thoughts, scary thoughts, anxious thoughts are wrong, and that must be pushed away. And when you push them away, you get the ironical effect. They come back with even more, even stronger. And research, in fact, has shown us that suppressed thoughts are characterized by increased return of the suppressed content. And you may be familiar with the polar bear experiment done, I don't remember in which year, in which they show people a polar bear and then they told them to try to not think about the polar bear. And it was impossible. So when we tell our patients, and it's something I hear very often from my colleagues during the year, saying to the patients, trying to be positive, things will be all right, don't think too much about it, don't stress too much. Thank you. If she or he could have done it, you would have done it already. You don't need to tell the person, think positive, or don't stress about it, or don't worry. So acceptance commitment therapy and cognitive diffusion actually teaches us how to do this from another perspective and how to take a step back. So I think that cognitive diffusion is something very powerful, but as we said before, people who have a high level of cognitive fusion don't even recognize they're having thoughts in the first instance. So they think that is the truth. I have a bad back. That is the truth. It's not even a thought that is passing through my mind. They think that is the truth. So before going and using fancy techniques and very nice techniques that acceptance commitment therapy offers, I think the first step with these patients is helping them being more aware of their cognition.
And now from Finland, it's physiotherapist Rika Holopainen.
Yes. So first of all, the physiotherapist reported that they've started seeing pain as more multidimensional, including also the psychological and social aspects. And some of the training interventions had taught physiotherapists to use questionnaires to identify these factors. And the physios had started using the questionnaires. Then there were some breathing relaxation exercises that the physios started to use. And also they understood that the care needed to be patient-centered. Like before, some had been like the fixers and doers in their work, and they started giving more responsibility for their patients. And I think a big theme was also that many physios reported that their therapeutic alliances started to get better and their communication got better. Quite a lot of them also started using the approach wider, which means that if the intervention in the study they participated was about low back pain, so they started using their skills also with patients who had knee pain or stuff like that.
And from the United States, physical therapist Matt Erb.
And so I'm going to preface what I'm going to say by suggesting that my hope is at some point in the evolution and our co-creating and mutual learning around improving healthcare that labels will not be needed. But I have chosen, and this can be loaded as well too, as I'm sure you know, the word integrative, which is a derivative of the word integral. And so when I look at the idea of biopsychosocial, I see that if we can see that as a whole, and potentially also acknowledge that there are spiritual facets to people's lives, which could be added into the psychological compartment, for example, or cultural aspects of people's health experience, which could be technically put into the social, that I believe, that's my personal preference, that integral or integrative is more encompassing. In this regard, we can look at the construct of body, mind, and environment. And I know you've had Marlisa Sullivan on here. In her paper on the explanatory framework for yoga therapy, she introduced that abbreviation BME as seeing that body, mind, and environment are inseparably embedded into a living system. And they can't be, sort of removed from each other. And so the idea of using integrative is to look at biopsychosocial, but adding in other levels as well as certain constructs.
UK physiotherapist now living in Canada, Tom Young.
I think some of what we do more traditionally, there's something kind of seductively complex about it, kind of thing. All the kind of like regional interdependent models. I'm going to watch you walk. You've got shoulder pain. Okay, well, your ankle's pronating 10 degrees. And if we fix that, and so I don't know. I think just accepting that maybe that A, doesn't have the best evidence to begin with, and B, but letting go of that sense of maybe I'm not quite as clever as I think I am. And that's actually a challenge. I think you kind of acknowledge your own, I guess, sense of intellectual vanity almost, and kind of letting go of that a little bit can be a challenge. And again, sort of answering what you expect a patient needs. So when maybe you encourage a patient to do something, and in the session they really buy in and they're like, yeah, this is so important to me, this is awesome. And then they have a really big pain flare. And then there's that sense of, you can either swoop back in and try and save the day and say, here's what we're going to do, we're going to control this, and back off. I think that robs people of agency. So I think, again, part of that is just trying to model a boldness about pain and sort of, okay, you had pain, but what else came up for you? Was there some excitement when you did that thing? Was there some joy in the moment? What else was there room for in that moment? And I think the more I've done that, the less of a kind of win-loss there is as a kind of frame for me. And I think that's kind of what's freeing. So I think trying to fix chronic pain is kind of like banging your head against a wall. And I talk a lot about patients letting go of that fight. But me as a practitioner also has to do that. If I'm still sort of secretly like, but all of this is to really make you have less painful experience, then I keep on kind of feeling that loss. That's not a battle I'm winning. So I think to truly sort of let go of that control for myself as well, and be willing to model a boldness again about pain, it's quite liberating too, and just always bring it back to, okay, that happened, but what else? What's important to you?
Australian physiotherapist Samantha Boonsley.
This model really helps physios to understand how we can play a role. And I think often physiotherapists are really worried. You said that line with maybe the pain psychologists and feeling like maybe we don't have a role to play in managing those emotional responses to pain and that's distress. But I think this model really shows that it helps physios understand that we do play a role, in my opinion, in addressing those emotional responses by helping people make sense of their pain. So this is something that is well within our scope of practice, in my opinion. And I think that we also play an important role as far as belief change going hand in hand with behavior change, but maybe I'll talk a little bit about that in a moment. For any clinician that has a patient coming to see them with pain, I think it's really important that we know how that individual is representing their pain. We need to tap into these 5 belief dimensions. So how do they make sense of their pain experience? So we can ask them questions around that identity domain. So do you have a diagnosis for your pain? Can you explain to me what that means? So that problematic interpretation, some of the jargon. Have you had any scans? What did the scans show you? So trying to look around with those beliefs. Around the cause domain. So do you know what causes your pain? And how predictable is your pain? Is there always a cause and effect? How predictable is that cause effect? The consequences of your pain. What do you think the consequences of your pain or your diagnosis are? Can you prevent your pain from flaring up? So around that control domain. And can you control the pain once it's flared up? Patients often distinguish between those 2 control factors. And then the timeline belief. So how long do you expect your pain will last? How hopeful are you for the future? And what do you think it's going to take to get your pain better? And as clinicians, we should be really listening for any gaps in understanding that we need to help fill, or any incorrect beliefs there that we need to maybe to try to adjust. And that's where I think behavioral techniques are really important, because obviously I've done a lot of work with PEAT and CFT, and that really puts a lot of emphasis on exposure to feared movements and activities as a mechanism to disconfirm beliefs.
And to round out today, we have Brazilian physiotherapist now living in Australia, JP Canara.
For ask any grandmother and any mother around the neighborhood, everyone will tell you that round back is a bad thing for you. There's this belief around posture. So we're probably tapping into the information that is most readily available in our society. And that is quite interesting because it kind of gives us an idea that, if you look, for instance, at Ben Darla's work, he did an extraordinary work around capturing people's beliefs, explicit beliefs, self-report. And there is this idea that the back is easy to harm and hard to heal. And then we looked at this population, and implicitly, they're making the same associations. So that creates what we think is this really strong schema that, you might be going on about your life and everything is fine, and then you experience pain. And once you experience pain, your brain is probably going to tap into that schema and go, oh, okay, I have back pain. What should I do? I shouldn't bend, because that's what my implicit schema is telling me. And then you go and you talk to your friend, you talk to your neighbor, you talk to healthcare professionals, and they reinforce this schema. And what we think potentially happens, and that's a speculation on our data, is that you have this update of the schema that goes from just, bending the back is dangerous to protect the back from now on. And especially if your pain is related to bending. So you bend forward and you think you're rounding your back, and that reinforces that schema, and you get caught up in that idea. So that ideation has a behavioral response that may get people trapped.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit Integrative Pain Science Institute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.